Thank you very much, David. Thank you, everybody here at the University of Louisville, for your generation of excellence in the field of medical humanities and bioethics. I know just how extraordinary your program is here, and I'm delighted to be able to contribute in some small way. Now, the Holocaust Deadly Medicine exhibit is overwhelmingly powerful. I'm sure all of you here at one point or another have had a chance to wind your way through the murals and recognize the tremendous horrors of medicine at its low point, perhaps in all of human history. What went wrong? Many people will approach that question in distinctive ways. There'll be talk about Galtonian notions of human progress, that somehow we can speed up progress by eugenics, by breeding creative geniuses with other creative geniuses. Others will talk about the impact of the sterilization laws applied to the mentally feeble, all of which emerged remarkably in the United States, first in the state of Indiana, but ultimately spanned across 35 of the states and issued in the amazing Supreme Court case of Buck v. Bell, and some of the nefarious quotes from even wonderful people like Oliver Wendell Holmes. So we can interpret the horrors of the Holocaust and of the descent of medicine and the medical profession to this low point in many ways. What I'd like to do is, in a certain sense, address this through the prism of medicine at its best, and perhaps make a contrast that will be useful for you as you go forward in your careers. I want actually to talk about compassionate care, about the very thing that was missing in the era of the Holocaust. Now, in today's medicine, if you approach the person on the street corner, you ask, what's the big issue in bioethics? Somebody might respond, well, I was in the hospital the other day and I was treated like a kidney in room 5. I felt over-objectified. I was a slab of meat on a table. It was dehumanizing, depersonalizing. There might have been ridicule. All of this, I think, is something that patients report, but also something that clinical practitioners feel as well, that somehow we've lost the kind of attentiveness to the patient's subjective experience of illness, to their humanity, to their dignity. We've lost the narrative of their experience. I think of the TV series House. How many of you watch House? Probably all of you, right? Where the patient is, to me, as I view it, more puzzled than person, right? A puzzle to be figured out and to be pieced together, but not really a person to be related to. So that's what I mean by the problematic of the loss of compassionate respect, if you will, in healthcare. Now, Jerome Groopman is a very renowned writer. He had the best-selling book, The Anatomy of Hope, which I do believe is the finest treatment of hope in the history of medical ethics, without question. Indeed, there is a wonderful chapter on the biology of hope, which talks about hope in a relationship to the endocrine system, the immune system, the release of endorphins, and so forth. He's a serious scientist. He runs the research program at Beth Israel Hospital. This is a comment from Groopman. The entire compassionate dimension of medicine, which is really key to the profession and which is so gratifying, all of that is threatened, severely threatened, if not erased, when you are put in an environment where you are constantly hectored around money and efficiency and making sure that time is minimized with patients in delivering care in order to maximize revenue. So that again is a perspective on contemporary American medicine from a very distinguished man. Now, there was a remarkably influential German physician who came to the United States, who taught at the University of Pennsylvania for many years and then went off to Johns Hopkins University, where he was the bedrock foundation of modern biological medicine. And that's, of course, Dr. William Osler, who was a remarkable physician who had himself a good bedside manner, at least as one hears him described. But I do want to say something about his thought that I think is directly relevant to the reality of German medicine from 1920 onwards. As he was leaving the University of Pennsylvania, he delivered a very famous address. Actually, that's not the right date. That would have been something closer to 1900, so I'll have to check that, but called Equanimitas. And that really means staying stable, not being rocked by all the vicissitudes and the clamor and the craziness going on around you in the clinical environment. He viewed emotions as disruptive, as irrational, as getting in the way of clear-headed delivery of good medicine. He idealized emotional detachment, pure objectivity. He had very little faith in the human capacity for compassion, for empathy, for tender, loving care, if you will. He was focused on this more arid notion of duty. And I don't want to in any way associate a great man like Osler with the realities of Nazi medicine, but I will just say that that ethos of objective detachment was absolutely dominant among the many Nazi physicians. That's what allowed someone like Mengele, for example, as he's described in Robert J. Lifton's wonderful book, The Nazi Doctors, where you get a kind of psychohistory of a dozen or so of the major Nazi doctors. You know, Mengele would come in the morning and he was effervescent, he was kind, he would take these little girls out of their cages and put them on his knee and even give them lollipops. But then come the afternoon, he'd put on his white coat, and then he was Herr Doktor. He was then Dr. Mengele, objective, detached, proceeding with medical progress of a sort. And at that point, then he would inject these twins with various chemicals and poisons to see how fast they would act, and that would allow him to understand something about human genetics. So it is this kind of torturous Jekyll and Hyde quality of Mengele that always strikes me. On the one hand, in his non-professional role, although he may have been sociopathic through and through, a certain kind of at least superficial generosity, but then this kind of coldness that he seemed to associate with being a good doctor. Now, even today, in American medicine, the finest scholar and researcher on empathy and compassion in medical care is Mohammad Reza Hojad at Jefferson Medical College, who's written a phenomenal book called Empathy in Patient Care, Antecedents, Development, and Outcomes. Well, even Mohammad Reza, who's a wonderful individual, leans toward this very cognitive interpretation of empathy. Empathy is about understanding. It's a hyper-rational perspective on empathy. Clinicians should feel the patient's feelings only to a limited extent to improve understanding, but don't actually allow yourself to, in any kind of direct way, resonate with the sufferings or the experiences of a patient. Harold Spiro, one of the great leaders for many years at Yale University Medical School, wrote this recently in Academic Medicine. Empathy is an emotion important to medical care. In saying this, I've long differed from the belief expressed by Hojat, and I might even say by Osler, that empathy comprises a cognitive skill. For me, empathy arises out of our own feelings and reactions. It happens when you and I become I am you or I could be you. For physicians, empathy is the spontaneous feeling of identity with someone who suffers, fellowship, if you will. So, what did the Zen Buddhist say to the hot dog vendor? Anybody? Make me one with everything. Who said that? Bravo. Okay. All right. You know, at some point, the moral life assumes a kind of glue, a kind of oneness between people. Contractarians don't have much of a sense of that, but if you're reading any of the great moral thinkers, whether it's David Hume or Adam Smith, or whether it's the Dalai Lama, for example, they're talking about some sense of a common or a shared humanity. And what Spiro is saying here is that that kind of sensibility is the absolute bedrock foundation of any kind of medical professional ethos. And without it, we can't really get any place. So I think that's a very interesting statement. There is a great scholar out at Berkeley, Jody Halpern, who's written a phenomenally good book, From Detached Concern to Empathy, Humanizing Medical Practice. And she really talks a lot about the bias in objective medical professionalism with respect to the value of these kinds of empathic emotions, those emotions that allow that kind of connective tissue between a physician or a nurse and a patient, and that tissue is so constitutive of what we would call, I think, the healing art. So she talks about emotional reasoning as an alternative to training in detached concern. She talks about how even the initial experience for medical students with a cadaver shapes them in certain ways, perhaps. I know in my years at Case Western, the first thing the students used to do anyway, was deliver a baby, right? And they saw their cadavers later, a semester later, and there was actually a purpose behind that. We didn't want their first introduction to a patient to be with a dead patient, if you will. Medical educators and professional bodies generally recognize the importance of empathy, but they define it in cognitive terms, including the AAMC, in a special way consistent with the overarching norm of detachment. Now, my colleagues at Stony Brook, Jack Coulihan and Peter Williams, wrote a very good article, I think, some years ago, Vanquishing Virtue, the Impact of Medical Education. And they said there's just a little too much emphasis on detached concern and affective distance, as though somehow that's a danger to optimal clinical care. Now, contrast Osler and this more Germanic tradition with a tradition that really begins about the same time, actually, with Francis Peabody. Peabody's lines are the most often quoted in the entire history of American medicine. When you go into Mass General Hospital, you look in the foyer on the left, ensconced in the marble wall, is that famous phrase, "For the secret to the care of the patient is in caring for the patient." Peabody gave this remarkable presentation to the Harvard Medical School graduating class that later appeared in JAMA. One of the essential qualities of the clinician is interest in humanity. Hospitals, like other institutions founded with the highest human ideals, are apt to deteriorate into dehumanized machines. Think about the great sister asylums on the East Coast that began in the 1830s and 40s as communities of compassion and moral treatment that then evolved into these dry, barren institutions that ultimately serve no one well. He wrote, "The treatment of the disease may be entirely impersonal. The treatment of a patient must be entirely personal. All of you have had experiences that have brought home the way in which emotional reactions affect organic functions." So here you have it, right? Look, when you walk through that Deadly Medicine exhibit, you see this, the kind of ultimate endpoint of pure detachment that allows otherwise caring doctors, perhaps, doctors who are good to their children, good to their neighbors, good to the nearest and dearest, and maybe good more broadly with their acquaintances, but somehow or another, in the name of detachment, they're allowed to perpetrate these hideous acts on innocent children, for example, or people who are feeble-minded, people with dementia, people with cognitive disabilities, taken out of institutions between 1938 and 1940 in the famous Tiergestrasse 4 project. These were people who would then be left overnight in vats of cold water with ice to see how quickly they would freeze. And then could you bring them back into the asylums and thaw them out, quote unquote, in different mediums, water, air, at different temperatures and so forth. Right? So this was the ultimate statement of pure detachment. And Peabody is reacting against that kind of thing. Now, in American medicine, we talk about the biopsychosocial model. George Engel's work, which is very much indebted to Peabody at the University of Rochester, he actually added a scientific analysis. He looked at the ways in which emotional states affected actual healing outcomes. His group studied distrust, loss, despair in relation to physiology and immunological impact. He began a kind of science of care, which I think is something that every medical student and every nurse and every healthcare professional needs to be very attentive to. So what about this problem that I've laid out, the over-objectification, the over-biologization of patient care in the name of this kind of detached objectivity? Not that objectivity to a degree is a bad thing, it's not, but it can go too far. Well, some talk about the time factor in healthcare systems. There's a tendency in our own thinking to believe that care is fundamentally a matter of biotechnology. There are negative hierarchical structures. We confront those in our medical school and in every medical school. In fact, as Hojat points out in a recent article, medical students come to medical school quite committed to compassionate care. It's in that third year when they get into the clerkships that things drop. And it drops because the role modeling isn't right. Maybe they've learned a lot about care and compassion and medical humanities in the first 2 years, but then in the clerkship environment, some resident says, well, that's unimportant, that's soft, that's silly, right? So, they get acculturated into an environment that sends the wrong message. That's what I mean by a negative hierarchical structure. And by the way, Stanley Milgram did the famous studies at Yale University in the late 50s and early 60s, trying to understand more about the Nazi personality. He wanted to understand why it was that so many otherwise perfectly normal, good, decent people committed themselves to Nazi ideology and Nazi viciousness. So you know the story where he would bring people in off the streets of New Haven. He had paid actors and actresses in a room. They could not be seen visibly by the subjects, and the subjects didn't know that these people were being paid. But basically what Milgram did, he stood there with his big white jacket on over these subjects, and he said, listen, I'm going to read a set of words, cow, giraffe, Honda, Civic, Toyota, and I want this person who you can hear but not see to repeat those words. And if they don't repeat them back to me, I want you to hit the juice. So hit this electrical switch, and that will provide a shock. Well, what happened was, of course, that the actors and actresses feigned forgetfulness. They stumbled with their memory, and only one-third of the subjects in the experiment voted with their feet. They said, listen, Dr. Milgram, I don't care what your situation is in life, what your expectations are. I'm not going to electrocute another human being. But two-thirds of the people there did in that study. In fact, the voltage got very high, and the actors would be screaming bloody murder, help, shrieking, right? But people would continue on with this. And so the lesson is that if you take a room full of 30 otherwise decent people from the streets of Louisville, perhaps, and you give them this kind of situation, for two-thirds of them, their compassion, their natural hardwired compassion, we talk about mirror neurons, we talk about the compassion axis that involves the activation of oxytocin, vasopressin, and so forth under conditions of a shared fate. We know that's there. We know that's wired into us. We know how deeply evolved it is in human nature, but it is overwhelmed in two-thirds of us by a hierarchical situation. So if we have someone who tells us to inflict harm, a majority of us will go right ahead and do so, even though we may feel torn because of that axis of compassionate emotion. So that's something you want to remember, that wherever you are in a medical environment, every one of us has to be modeling compassionate care for everybody. And that goes in every clinical environment, in every conceivable hospital. It's got to be part of residency training, because we can do damage and we can create the kind of cynicism that's reported. 61% of residents in American training programs believed that they had become more cynical during their medical education. My friends, that is an indictment. Now, is gender relevant? Yes. Female physicians are more likely than male physicians to engage patients in positive conversation and discuss social and psychological issues with them. Simple things. Hey, how are you dealing with this? I bet this is tough. You know, just a simple line or two usually elicits the kind of connective glue, that sort of oneness that is the basis of a moral life and a moral community and of a healing relationship. It doesn't take a lot, but it just takes a little. And females tend to be better at it than males. Again, the third year, Hojat's article from just very recent, The Devil's in the Third Year, is something that I think every medical student ought to be reading. Well, how do we counter this? We can think about it in terms of admission standards, about clearly clarifying our expectations for compassionate care, simulation feedback, good role models, faculty development, focus in education, clerkship assessment forms, empathy pre-clerkships, which we used to do at Case Western. But generally what I'm talking about is a full spectrum institutional commitment to compassionate care across medical education. Now, all right, so you might ask, is everybody capable of compassionate care? There is a book, by the way, that was a bestseller several years ago called The Sociopath Next Door. And it turns out that 2 or 3% of people are simply incapable of empathy, of feeling the suffering of another human being. And they are not all serial killers. Some of them are CEOs, deans, no, I won't say that, no, sorry. Just kidding. No, people who can do hard things comfortably, if you will. But why is that? Well, you know, it can be neurological. You know, now a lot of neuroscientists, I see Rob Friedland there, are looking at mirror neurons, which are on both sides of the brain, and they're associated with our ability to feel the emotions and the activities of another just as if they were our own. So that's the great new science of human empathy. In other words, it's hard to be a naysayer, it's hard to be cynical about these things because we're getting so much biological data on the reality of this empathy system. Now, you know, Martin Buber, I think the great Jewish philosopher, captured the core of the moral life when he distinguished two ways of living. I'm the center of the universe, the planets revolve around me, I relate to other human beings only so far as they contribute to my agendas and no further, right? That's ultimate objectification. That's what was going on with the Nazi doctors, and Buber wrote incredible essays in his book, Man and Man, where he gave his assessment of the Nazi doctors. And he said that ultimately they were all finally responsible, even though they said, well, I was just obeying authority. In the great Nuremberg tribunal, Dr. Brandt says, I was just doing what I was told. That's what the doctor said at Tuskegee. So don't blame me, right? So again, obedience to authority overwhelms the innate capacity for compassion, for love, for humanity. Buber said, even the worst Nazi doctor would wake up at midnight realizing the contradiction in his life. The contrast to I-it is I-thou. I'm not the center of the universe. I relate to other people as ends in themselves. I honor them as fellow travelers in the journey of life. And it's a deep emotional transformation. Buber didn't believe that ethics was a hypercognitive adventure. He believed that it fundamentally was primed by emotional transitions. Let's recognize some people, it does seem, don't have the neurological equipment for empathy, and there are some for whom all the wrong buttons have been pushed, and that gets into attachment theory and moral development and relationships between parents and children and so forth, which I won't go into. Culture can be a significant factor as well. There are many ways to think about the nature of this kind of radical evil. And Lifton did a beautiful job, again, of providing a psychohistory of most of the Nazi doctors. Now, let's just shift gears here. So a picture's worth 1,000 words. Here's a picture of compassionate care. This is a gal named Stephanie who I met at the Iowa Governor's Conference on Alzheimer's disease about a decade ago, and she's amazing. She's an Alzheimer's clown. She'll go into a unit where people are severely demented, where they've lost the temporal glue between past and present and future. They're mostly consigned to the pure now and may not have uttered a coherent word for months. But there's a kind of a resurrection of a sort that occurs with Stephanie. She, first of all, has that right kind of facial expression and tone in her voice, and people with dementia or people with autism and so forth are extraordinarily sensitive to emotional dynamics and relational dynamics. And then she'll use touch. She'll touch this resident on the hand at the right moment. There is something about touch as a symbol of compassion, I suppose, of connectedness. And then she'll sing a song relevant to the resident's generational cohort, and that resident might chime in for a few lines because sometimes music is very deeply ingrained in memory. But again, this is a picture of the real essence of human healing. Don't ever think that it's just biology. That's what the Nazi doctors thought. It's a lot more than that. And in the final analysis, you can't heal unless you can feel with. Hojat writes correctly, because the drive for human connection increases during times of distress and illness, the presence of an empathic clinician is a gift of social support for the patient and epitomizes the human connection with all of its beneficial effects. This is, to me, the bio of ethics. This is where we begin to talk about the whole physiology of an ethical life. Let me just, whoops, what happened here? Are we okay? Somehow or another. I'm not forwarding. Steve there? There it is. No. Okay. Wait a second. Let me just ask my helper here. Not sure what that is. We're stuck. you can figure that out. Sorry. Okay. You okay? Let's see if that works. Okay, good. Thanks a lot. Yeah, I appreciate it. Okay, sorry. Oh, yeah, let's hit slideshow, right, which is, where's that? That's, okay. Oh, it's down here. I got it. Okay. There. Okay. So, so the point is here, ask those simple questions, be attentive to the subjective experience of illness, and recognize that when you do so, you're actually impacting the physiology of your patients. Jim House at the University of Michigan in Ann Arbor is the one who's done all the social capital theories on illness. Robert Putnam's great book, Bowling Alone, has a whole chapter on social isolation vis-a-vis pro-social interactions in relationship to morbidity and mortality. There's something about human connectedness that reduces fear and anxiety and has a tremendous impact. There's a remarkable study by Kiko Glaser. She runs the Psychoneuroimmunology Institute at Ohio State in Columbus. Medical students who were lonely had decreases in T helper lymphocytes. In a famous study in JAMA on susceptibility to the common cold that came out of Carnegie Mellon University, it was shown that people who have more social connectivity catch fewer colds. You might think intuitively the contrary. Stay away from other people and you'll be freer of colds. But actually, it turns out in the one pretty good study that we have that that's not the truth. So the studies we have on physician-patient communication associated with increased physical functioning, emotional health, even decreased feelings of pain. With regard to the benefits of compassionate care, you get more accurate diagnosis. That's very important. There are now 10 very, very good studies on this point. You get more accurate diagnosis when you approach a patient with empathy and compassion. Why? Because they feel an emotional safe haven and they're more willing to divulge or disclose things about them that you could never have anticipated, that you would probably never have even approached with the right probing question because it wouldn't have crossed your mind. So you get better, clearer diagnoses. You also get better patient adherence. Right now in American medicine, everybody's talking about healthcare rights. Do you know that 30% of healthcare expenditure in the United States this year is due to non-adherence, what used to be called non-compliance? The person who doesn't take the immunosuppressants, the person who doesn't follow through with this or follow through with that. It's a tremendous problem. This kind of stewardship, this kind of care of the self is not happening in the way that it could. Who has the longest lifespan in the United States today? Actually, Seventh-day Adventists. And it's related to sort of dietary attitudes and approaches toward medicine and toward the holistic vision of wellness. So adherence is important. You get better diagnosis and you get better adherence. You reduce patient anxiety. You get patient satisfaction. You have less frequent professional burnout. That's really interesting. People worry today, well, you know, physicians are leaving the field. Actually, one of the strongest preventions against leaving medicine is maintaining that attitude of care and compassion. And you even get enhanced physical healing, which I'll try to discuss a little bit in a minute. Okay, so do no harm. What does it really mean? Let's connect it with all of this emphasis on emotions and biology. Here's a study also from Ohio State University. An abrupt, arrogant, disparaging encounter, this between a physician and a patient, augments serum cortisol levels for 2 days. So up goes stress, right? Now the word dis, do you use that, some of you? You can, it's in Webster's 10th, right? Disrespect, that sense of, again, being a slab, that sort of objectification, that dehumanization, that's really at stake here. So when you interact with the patient in that way, you're shooting up their cortisol for 48 hours, and that has all sorts of impacts, not just with regard to vasculature, but also with regard to the immune system. I have a friend who runs the Forgiveness Institute at Stanford University, Fred Luskin. He wrote the bestseller Forgive for Good a few years back. He began, 15 years ago, studying mothers from Belfast, Ireland, mothers who had lost kids in the sectarian violence. And of course, you know, they were having a hard time adjusting in their lives. Many of them suffered from depression, from protracted anger and hostility. And he did forgiveness interventions with them, which I'm not going to go into, but some of you in psychology will be familiar with these things. And what he found was that he had lowered blood pressure in these women, reduced stress hormones, improved depression levels, and enhanced self-reported health. So we have to understand that when we're talking about compassionate care and about creating emotional safe havens, it's not just touchy-feely, but it really has an impact on physical outcomes. Aaron Lazar, the former dean of the University of Massachusetts Medical School, wrote a famous book called On Apology, where he talked about how important it is to teach medical students to make effective apologies, not so much for the medical students, but rather for their patients, because by making an effective apology, it liberates those who have been harmed from the kind of protracted rumination that seems to follow. Let me just give you one other really interesting, fairly recent study that I think is quite compelling. This is the Harvard Mastery of Stress study. So back in the early 50s, researchers picked out 126 healthy men. All the students at Harvard back then were men. And they responded to a simple questionnaire about how close they felt to their parents. And then 35 years later in psychosomatic medicine, here are the results. 91% of those who did not perceive themselves to have had a close relationship with their mothers 35 years earlier had serious diagnosed diseases in midlife, high BP, heart disease, ulcers, alcoholism, as compared to 45% of those who had close relationships. And the relationships with the fathers are also highly relevant here. So again, this gets to the dynamics of attachment theory and the ways in which the emotional dynamics of youth don't necessarily determine, but certainly influence long-term health outcomes. With regard to clinician satisfaction in living a life that is compassionate, that is caring, that creates a kind of, again, emotional safe haven for patients, the decline in enthusiasm in medicine among physicians is attributed by them to the inhibition of empathic care, and that's Abby Zuger's article in the New England Journal of Medicine. Clinician satisfaction with their relationships with patients serves them as a buffer against professional burnout, substance abuse, and even suicide attempts. And that's, again, been replicated in several different studies. Compassionate care is generally beneficial for nurses and doctors. In this recent study that I was looking at just several weeks ago, health professionals who volunteered to go on medical missions for just 2 weeks into South America, again, these are not in overwhelming circumstances like Haiti, for example, would be right now, but these are more ordinary circumstances. But that lowered their score on burnout scales, and they continued to improve in a 6-month follow-up. So there's something about sort of getting out of systems where people don't feel that they can fully express this kind of compassion and create the right emotional state for their patients. There's something about moving into an alternative environment and then coming back that may be helpful. It's not to say that, you know, physicians and nurses don't experience so-called empathy over arousal and the like. What correlates negatively with empathy? Aggressiveness, antisocial behaviors, hostility, depression, anxiety. What correlates positively? Emotional intelligence, social skills, likability, flexibility, moral judgment, sense of humor, and sensitivity. So again, pictures. So here's Dame Cicely Saunders. I first met her in 1999. She's a Templeton Fellow and one of the most amazing women in medical history. She invented the hospice movement, right? I mean, the hospice was just historically a place in the medieval period where travelers would stop as they were journeying across Europe or whatever, and they would spend the night in a hospice next to a cathedral or a monastery or whatever. And she analogized. She said, well, you know, dying is a journey. And so she took the word hospice and applied it to a whole new way of approaching death and dying. But here she is, you know, when I met her, she was 83 years old. She said, I can never retire. I still go into St. Christopher's Hospice every morning and I change bedpans as a kind of compassionate practice. And then she said, I sit on the ends of beds and I listen attentively to patients because I want them to know that even though they're dying, their lives have immense significance and value. So they need to be listened to attentively, and I want to have an affirming presence, she said. Well, she died a few years ago, and the obituaries about her were as long as your arm. I'm not going to go on too much further. I simply want to emphasize then that however you look at this, compassionate care is good for patients. It's good for caregivers. I won't go into the helper's high, but that's something we can talk about. Right now, in my own studies, I'm looking at the 12th step of AA, and it turns out this is just something to consider clinically. But those who fulfill the 12th step, which is helping other alcoholics, have a 40% recovery rate after 1 year of sobriety. Those who do everything else in the 12 steps except help others, except engage in this disinhibition of compassionate care and altruism, they have only a 22% recovery rate. That one made the New York Times. And so we're now working with AA in a massive national study on this particular topic. MS patients were trained at Harvard to make brief compassionate care phone calls to other people with MS. This was by Caroline Schwartz. And remarkably, those who made those calls at low thresholds, just again, brief 15-minute calls several times a week, after a number of months, showed self-confidence, self-awareness, lowered depression, and the like. In fact, there was a New York Times article about this, 29 ways of giving, in December in the science section. So this is really catching on. You talk about cardiology, and I'll end here in 1 minute. You'd all know about the Minnesota multiphasic personality inventory, which you take as 350 questions that gives you an assessment of your emotional strengths and the like. Well, Redford Williams at Duke looked at people who took that test in 1950 when they were 25 years old. He did something brilliant. He picked out the 21 questions that he most associated, it's actually 27, but then he reduced it to 21, that most characterized hostility. Quickly agitated, prone to violence, uncontrollable anger, uncompassionate, and so forth. And guess what? The high quartile hostiles had a mortality rate of 20% by the time they were age 50 in 1975. The low quartile hostiles had a mortality rate of a mere 2%. And this changed American cardiology, because when I was growing up, if you were a type A personality going from type A to point A to point B in a New York strut and multitasking, people said, well, you're in trouble. But that's not it. The trouble comes if you leave this meeting or leave school this afternoon and you fall full-breasted on your horn because the person in front of you has the audacity to stop at a yellow light, then you're in trouble, right? It's the hostility that associates with the stress and the problems that follow from that in the vascular system. So I'm going to just end here because I don't want to go too far. But there is one, I'll say one last thing. This is probably the most important point we can perhaps bring from this presentation. The most famous longitudinal study of children in American research history hails from the Bay Area, from Berkeley University. It began in the 1920s, where researchers in the Center for Human Development picked out 300 preteens, that means basically 12-year-olds, and they followed them over the entire course of their lives. They did psychological interventions every 10 years. They looked at medical records. They did testings of various kinds, gave them questionnaires on happiness, self-reported happiness, and the like. So that 1/3 of these preteens who said, you know, I have an altruistic attitude in life. I want to do something to help others. They were, in comparison with the 2/3 who didn't have that sort of attitude early in life, the ones who had the altruistic attitude were much lower on depression rates, again, across their entire lives. They had lower rates of heart disease, lower rates of asthma, lower rates of diabetes. It's quite a long list. This was all published with UCal Press 2 years ago by Wink and Dillon in the course of a lifetime. The article appeared in the American Journal of Public Health. And now guess who's alive, my friends? These are people in their 90s, right? So 2/3 of the ones who were still living in their 90s come from the 1/3 at age 12 who expressed a compassionate, caring, altruistic attitude. I want to use my gifts to contribute to humanity. So however you look at it, you know, the art of healing involves, for the good of your patients, this kind of compassionate love. But it's also the case that for your own well-being as professionals, and when you look at life in general, it's good to be good. So that's my message. Thanks. Yeah, please. Hi. Shout it out, because.
All right. It's a nature versus nurture question.
Okay.
And I'm wondering if this sort of generosity, altruism, empathy can be taught, or does it have to be more of an innate skill that someone's born with?
Yeah. So nature versus nurture. Science is a little bit nascent in these areas, but in general, I think positive psychologists would allow that people do tend to have different genetic set points. This is the same with respect to, for example, self-reported happiness, right? Somebody can win the lottery and they'll be euphoric for a while, but then they'll eventually get back to their set point. People can be involved in a big car accident and become paraplegic, and they'll be depressed for a bit, but then they'll rise up to their set point. So there is a genetics to this. No one would deny that. We've tried to do some twin studies on altruism. The science is not very far along, but I would concur that I think for some people, biologically, their compassionate care system is more finely tuned than it might be for others. But having said that, I don't at all think that these biological elements are determinative. I think that Mary Ainsworth at Hopkins did the wonderful studies with Everett Waters, The Strange Situation. Styles of interaction between parents and toddlers was very significant, and in fact, when there was not that sort of emotional attachment occurring early on, they actually looked at those kids as they grew up, right, and they became 18, 19, 20 years old. The ones who had the insecure attachments were described by their peers. It wasn't self-report. They were peer described as lacking friendships, lacking a kind of warmth and compassion and so forth, vis-a-vis those who had what Ainsworth and Waters called secure attachment. And this goes back to John Bowlby and Harry Harlow and all of the work in the 1950s. I think that nurture matters, environment matters. But as George Vaillant has pointed out in Aging Well, his bestseller, with the Harvard study in adult human development that started in the 1930s with Erik Erikson, and that Vaillant took over. You know, you can have these deficits early in life, but you can overcome them. You can have the right non-parent mentor as an adolescent. You can connect with the right community. You know, Carl Jung said you'll never overcome alcoholism unless you connect with a spiritual community, and AA is basically what that is. Valiant points out that you can have the right spouse who models a kind of empathy and lets you feel that kind of emotional connectedness. That can help you become an efficient cause of compassion yourself. And so it's not that, you know, either the set point or the early life experience is fully determinative. Jerome Kagan points this out, the Harvard psychologist, in his book, 3 Seductive Ideas, where he really shows the inadequacy of the hard determinative perspective. So these things are fairly malleable, and you know, don't ever give up on anybody. That's what I'd say. But nature, nurture, and then finally, the positive psychologist would say individual choice. So, you know, Lincoln and his melancholia, which involved Louisville, you know, I'm told, where he would come here for treatment, he probably had a certain set point. And there were probably certain hardships he experienced, like the early death of his mother and so forth, that contributed to his melancholia. But then he also said famously, you know, when I do good, I feel good. When I do bad, I feel bad. So he would be found out on the streets of Washington, D.C., for example, unescorted with his top hat, and he was already 6'4", just helping people randomly, random acts of kindness. He was the original. You know, he'd go to Union Station and help somebody carry a suitcase onto the train. And he just felt that by making a determination to contribute to the lives of others, that would be beneficial to him. And that's an idea that goes right back to the beginnings of American psychiatry with Kirkbride and with Scattergood in the Philadelphia Asylum and Moral Treatment. You know, they hired Olmsted to build the 100 acres of sweeping hills, and they said, okay, melancholia, right, go out, milk the cows, bale the hay, paint the barn, serve the food, do things to contribute to the lives of others. That also was part of the 1960s renaissance of the clubhouse movement, beginning in New York and then spreading across the country, where people living in their you know, ordinary homes and so forth, but with histories of depression, would join the clubhouses, and they just have pro-social tasks, chores, the groceries, the lawn, and so forth. And now that's actually being built by Tom Innes into the recovery models for depression. And there are lots of studies now on pro-social activity in relationship to the endocrine system and the like. So there's, you know, again, it's a nascent science, but it's very important. So I think it's set point, it's nurture and environment, but it also at a certain level, as Lincoln said, and I'll quote him here, a man, I should say a woman, but you know, a man is just about as happy as he makes up his mind to be. And Lincoln was no fool. Yeah.
Now, could you repeat the question?
Yes, I will.
I was going to ask about, you said that you think there's like this genetic set point, and I was curious to know if you knew of any evidence that actually points to a specific gene that may actually be tied into these.
Is there some identified gene in terms of compassion?
Maps the human genome.
Yeah, there isn't. There is not, and I don't think we'll have that for quite a while. We do have twin studies, but they don't get genetically specific. Although there are some people who have claimed to have found a set of genes that they think contribute to compassion and altruistic behavior, and we may find out more in the future. But right now, I think the genetics is a mystery. Yeah. Someone else, please. Oh, yeah.
In terms of moral erosion, particularly as it occurs in clerkship, what have you seen in terms of the literature showing what can potentially stave off that kind of erosion?
So,
what interventions can physicians working with young medical students
right.
do at this level?
So given the moral erosion of compassionate care in the third year, what kinds of practical interventions might be available in clerkships to enhance this? Well,
Or in residencies as well.
in residencies as well. I think that's where we need to go now. I mean, we have all sorts of good data highlighting how important this dynamic of compassionate care is. the question is, how do we translate it into institutional structure? And what I'd say is that whole institutions need to be committed to this at every level. Administrators, deans, teachers, clinicians, everybody needs to be on board with this. In other words, it takes a village, is what I would say. We did something at Case Western which was fairly interesting. If we had a student who was identified by patients as really deficient in any kind of empathic capacity, we did something called a pre-clerkship clerkship. We would actually bring that person out of clerkship and set them up with a couple of clinicians, typically in family medicine, by the way, who had a wonderful reputation in the local community for treating patients with this kind of compassionate respect. And so these selected students, as a bit of a remedial task, would follow these clinicians around, sometimes for as long as 6 or 8 weeks. So modeling is the bottom line. Now, you can stand up and you can exhort people to this behavior, but that only goes so far. You can bring science in because it gives it a kind of validity in our modern world. But in the final analysis, I think, David, this is a behavior that is transmitted from one person to another. And so hopefully every clinician who is deeply caring can look back, or every nurse, every clinician of any professional background can look back on a certain set of individuals, or maybe one particular individual who was particularly adept at passing the torch, shall I say, in a kind of generative way. I think that's really the key item. But it does take institutional commitment at all levels, and I do think that the fall-off in the third year is particularly damaging because it sends the message that, well, you may have studied about these things in the first 2 years. You may have done courses on literature and the illness experience, and you may have been sensitized to this kind of subjective element in a patient's experience. But hey, when you get out into the real world, i.e. the clerkships, this is completely useless, right? And that's a bad message. Yeah, please.
Unlike other professions, physicians and dentists take an oath upon graduation. Do you think that the oaths that we take should be modified or updated over the Hippocratic oath and several of the modifications that have come out since?
Yeah. Well, that's an interesting comment. So how does this bear on oath-taking, whether in dentistry or in medicine and nursing and so forth? I think that, by the way, the very word professional focuses on the notion of oath-taking, right? I mean, a career, careo, is just something that gets you through in life. Occupation, occupare, is just a way of sort of filling in time to pay the bills. Professio means a public profession of a commitment to an identifiable constituency in need, formalized through a public oath, right? That's the definition of professionalism. Now, of course, in the modern world, we use the word professionalism much more broadly than we did historically. But I do think that the oaths ought to actually be explicit about compassion, compassionate care, and the like. The WHO renditions of the Hippocratic Oath and so forth don't include much of that. Actually, you get more of it, interestingly, in an entirely different tradition of the medical oath, the one that comes from Thomas Percival, Percival's Oath in England in 1802, which was the foundation for the first medical oath in the United States in, I believe, 1850. But I have to look. Is it? Yeah. Yeah. Right. And there, there is a much greater attentiveness to emotional dynamics, and so the physician should be a minister of hope, a minister of care, and so forth. And it is there in Percival's writings, but somehow it gets lost, and I don't see it in what people, um, the material that people forswear in medical schools these days. Although language is, dignity, respect, and so forth is there, but compassionate care explicitly would be an interesting addition. Yeah, please.
Getting back to the other question we had about third-year medical students, one of the things that the University of Louisville Medical School is doing is providing exclusive exposure to medical students, actually 3 of their 4 years,
Mm-hmm.
to palliative care and hospice.
Uh-huh.
It includes for all third-year medical students a week with a palliative care team nurse who teaches psych. And so the idea there is to try to give them, well, first of all, they should model
Right.
medical care in the context of end of life and suffering, but also, too, to give them tools so that they know what to do when confronted with this in other rotations, so they don't have to repeat behind the wall cynicism of health. So
Right.
the hope is that we will reduce
Good.
that cynicism.
Yeah, so I think everybody may have heard that, but your comment is that here at the University of Louisville, all the students in medical school rotate through, all third-year medical students rotate through a palliative care or hospice service for a week. I think that's a good idea because it sends the message that care doesn't necessarily mean a tube in every orifice, natural and unnatural, right? It gets them to care in the more basic sense of the term. Usually people who handle palliative care services or who are involved in hospice are self-selecting, and at least in my experience over the years, they tend to be particularly caring people because they have to spend a lot of time with these patients and their families. I mean, I know at Stony Brook, Lynn Hallerman runs our palliative care unit, and she tells me that she oftentimes spends 2 to 2.5 hours with each patient on a daily, I mean, so she might only see 4 or 5 patients on a given day. It's not particularly cost efficient for the institution, but she's profoundly committed to, the basics of compassionate care, and you can sort of feel it when you're around her palpably. And Cicely Saunders was very much like that. I mean, when you were around her, you just felt this kind of effervescence. There was a sort of buoyancy about her. I mean, it wasn't glib cheerfulness. It was just this sort of radiance, in a sense, that she seemed to have in her generativity and her kindness and her remarkable attentiveness to detail. I mean, Mother Teresa said that there are no great works of love, but only small things done with great love. And Helen Keller said roughly the same thing in slightly different words. I think Cicely Saunders understood that. So I agree. I mean, that's maybe one of the responses to David's thoughtful question. What can we do? And having everybody rotate for a week in the third year would be through a palliative or hospice environment would be a nice antidote to some of the things that they might pick up in other environments. Yeah.
I'm trying to understand more fully how you see the connection between this kind of altruism and empathy and the healthcare professional arriving at better ethical judgments, making better ethical decisions. And
Right.
what I can infer so far is that if one comes to appreciate the subjective life of the patient more fully, that somehow will provide what? More information about the
Oh.
patient's reality such that that information is essential for making really good ethical judgments.
Yes. So the comment is, what's the connection between this compassionate care motif and the making of better ethical decisions? Okay, a couple of things. First of all, when I look at a lot of the cases in the literature on medical futility, what I find is that there were communicative issues, relational issues. There was a lack of emotional intelligence, if you will. And I think we need to recognize that when a patient or a family feels that they've been treated in an abrupt way, that their perspective, their values and so forth haven't been honored. They're not going to be as communicative as they might otherwise be. So I do think that that kind of emotional rapport building is the groundwork of good ethical outcomes. Now, reason has a big part in all this, but to me, reason in the moral life is not the shaping reality. I think it's instrumental. In that sense, I'm beholden to David Hume and Adam Smith and others. It's instrumental. It forms the direction of these underlying moral sentiments, if you will. So I'm not being anti-rational here, but I think it's a mistake to believe that the moral life is primed by reason and reason alone. I do think that people are freer in expressing their deeper values and wishes when they are in an emotionally comfortable circumstance. So that is basically what I would say. I think one of the problems of the sort of modern bioethics movement, as it's emerged from particularly philosophical circles, and I distinguish bioethics from medical ethics in certain ways, but it has been so sort of theory-driven and hasn't paid attention to the emotional, relational element. So that's what I would say. Even more deeply, though, I mean, I'll tell you, I had an occasion to meet with Peter Singer, the utilitarian, and Eva Kitte, who's the foremost ethicist of care in America these days, and has for many years cared for her daughter Sesha, who has severe cognitive disabilities. And so in this remarkable encounter where Singer said as a rationalist, well, how can we really seriously consider people with severe cognitive disabilities? They're just not persons, right, in the sort of full sense of being able to act autonomously and to project plans that can be implemented into the future. And Eva Kitte said, well, why don't you come visit me and Sesha and actually get to know her for what she is, and so forth. I think the part of the emotional dynamic is just the recognition that epistemologically we have no real business making judgments about the lives of other people until we actually meet them and encounter them. And that encounter is a kind of I-thou encounter. I mean, for Buber, I-thou is not hypercognitive. It's fundamentally a kind of phenomenological interaction that involves the emotional self. Yes, Levinas's work on the face is absolutely paradigmatic, and so it's even respect itself. I mean, I know this is Kant wouldn't necessarily agree with this, but to me, respect itself is driven by emotion. It's driven by some sense of reverence or awe, shall we say, in the presence of another, which is again a theme that Levinas would buy into very explicitly. All of this is emotionally primed, and that's why Hume said, David Hume argued, convincingly, and Annette Baer and others have argued in more recent times. If that sort of emotional connectivity isn't there, then we're not primed to lift a finger to help the other, right? I think we just need to bear that in mind. Yeah. Yeah, please. Hi. Yeah, the ever-shrinking office visit and the 15 minutes and how that's affecting all this business of compassionate care. So, Hojat has studied this, and a few others have as well. And here's what seems to be the case. If you have the sort of standard 15-minute visit that you're trying to grapple with in your everyday clinical life, if you make that brief empathic statement, the connective statement, how are you handling this? How are you coping? And just sort of connect a little bit, and it doesn't take a lot, right?
But you know that's dangerous. Not to interrupt, but
Yeah, no,
it's a little dangerous to ask that sometimes.
can be dangerous. Well, I mean that's interesting. Dangerous because
Because you're in for another 30 minutes.
you're in for another 30. Okay, so you're in for another 30 minutes. Actually, not the case. I mean, you can be in for another 30 minutes, but the studies that we have on this point out that yeah, you can a 15-minute visit might be extended to 17 or 18 minutes, but not but if you keep it under control, it's just not a carte blanche. But you want to do enough, and so that you can have the sorts of benefits that we are now seriously aware of for the patient, as discussed. And so it's yeah. I mean, to say that's dangerous. Well, I think that's something that we can handle. I mean, I don't think that your fear of this extending into a 30-minute or a 40-minute conversation. I think you have to be able to control the flow of things, but to do that doesn't mean to be abrupt and ignore that element or delegate it to nurses, which is sort of what can happen in clinical environments where But I think it's an interesting point.
I just think it's interesting that pressures outside the clinician's control are influencing.
Yeah, pressures outside the clinician's control, and that's exactly Jerome Groupman's point. Where I mean, that's what he's saying is that, you're so inculcated, with concerns about time, about money, about billing, about insurance, that you you lose sight of the real humanity of the healing art. Yeah. Yeah, please.
Along those lines, I have a clinical practice, and I'm sort of torn between an overhead of $300 an hour and upward limits as dictated to me by various government programs and insurance contracts and that sort of thing. And many times I find myself actually going in the hole taking care of patients. There is a limit
Right.
how far you can go with it. And, what we do in an effort to try to teach our students how to cope with this is we push them to ever increasingly high levels of efficiency, such that they really don't treat the patient. They treat charts, they treat CTs, they treat blood panels, they treat other tests and diagnostic issues. Many times I ask my students, when was the last time you took a patient's hand,
Right.
looked them in the eyes, and said, now tell me, what do you think is wrong with you? We don't do that anymore. And the reason is because we professionally have lost control of our profession. It's being dictated to us by outside forces that seemingly are beyond our control. I don't really believe that, but seemingly they're beyond our control. And I understand why people leave the profession.
Right.
I understand why people leave the healing arts. What are you going to do?
Yeah, so to quickly reflect that back, that in everyday practice there are so many constraints, including financial ones that emerge from health policies of various kinds. There's also the constant issue of biomarkers and technological approaches to the patient, which I mean, those approaches grow and grow and grow exponentially. So what happens to the old art of just putting your hand on the hand of a patient and asking them, well, what's going on with you? And you understand why people leave the profession, because that aspect of care, which I think implicit in your comments, you find rewarding, right? Very rewarding. that seems to disappear at times. My response to that is, well, you know, the system is the system. You know, it's possible. There's no question. I mean, it's almost like the literature on medical mistakes. I mean, you can think about how all the structural elements, financial and otherwise, feed into this lack of connectiveness, right? But in the final analysis, you know, every individual, every professional has to just commit to this. You just have to commit to this. And if you do that, and you do it in a mindful way, I'm still convinced that you will prosper, and that your patients will prosper. We need to work harder at it. We need a system that is more sensitive to this element of healing. But in the end, I'm a bit of an existentialist, as Buver was. You know, I think that we, each and every individual, are finally responsible for the way we live our lives, professionally and otherwise. So it sounds to me like, despite all of these obstacles, you're still doing what is most meaningful and significant to you in clinical care.
I can't work within the system, though.
You can't work within the system.
I network with the insurance companies. I don't accept payment from insurance companies.
Mhm.
My deal is between me and the patient. The patient's deal is between them and the insurance company.
Right.
Okay? What's happening, though, on a national level, is people like me are being increasingly marginalized. We're being increasingly pushed away. And ultimately, it may well come down to, well, if you want a licensed doctor, you will sign up and you will accept what we pay. If not, then you cannot practice any longer.
Right. So,
that's where it's going.
yeah, and so this is a complicated matter of these external financial pressures. Again, you know, Groupman touches on those seriously, and as do you. You know, I do think that one of the reasons why alternative medicine is so popular in the United States is because people don't feel that they get the kind of compassionate care that they need in the sort of standard allopathic environment, so they look elsewhere, and sometimes to their detriment, because they don't get the sort of proven interventions that could be very helpful to them. So that's an important factor in and of itself. Yeah.
Other questions before we go? All right. Thank you so very much, Professor Bowe.
Appreciate it. Okay. Thank you.